Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
In this presentation, we're going to study our mandibular incisor teeth. Our objectives for this presentation are, number one, the location and position of these teeth, as well as their function. We're going to study the occlusion. We're going to help identify our morphology on these and the terminology that describes these teeth. And we're going to go over and review our identifying characteristics of these teeth. Our mandibular incisors are the four anterior teeth which are located on the mandible in the anterior area. And they each have numbers. We have number 23, 24, 25, and 26. Now there are other numbering systems that we can get involved into, but we're going to use the basic 1 through 32 system, which brings these out to be 23 through 26. In looking at the function of these teeth, we find that, of course, they're used as our maxillaries are in incising. And actually, our maxillaries are fixed, and this is more of our movable cutter bar motion on these mandibular teeth as far as the function. They increase the functional activity of these considerably in our cutting or incising portion. We're concerned with aesthetics with these mandibular anteriors in dentistry. And as we mature, these mandibular teeth become probably more prominent in aesthetics. As our facial musculature generally sags, we start showing more of our mandibular incisors and much less of our maxillary incisors as we mature. Of course, we're also involved with our speech and phonetics on these teeth. Our mandibular centrals are the ones which sometimes are referred to as the first permanent teeth to erupt. They come in about 6 years of age, plus or minus half a year or so, but they can't always be the first ones because they vary a little bit. And our mandibular first permanent molars also come in about 6 years of age. Mandibular and maxillary are about the same. And sometimes first molars, permanent molars, will come in ahead of our mandibular incisor, sometimes vice versa. But of course, these are the ones that are up front, and we have to lose a baby tooth or a primary tooth here before these will come in. And so these are the ones that make a big change in the child when they start losing their baby teeth. Our permanent molars, first permanent molars when they come in behind the deciduous teeth, so we're not involved with any changeover of teeth in that area specifically. Let's look to our occlusion. We should identify occlusion. By occlusion, we generally mean the arrangement or the relationship of the teeth in the maxillary and mandibular arches. This involves the way the teeth fit together and the way they occlude and bite and function. And so we're generally involved in this as far as occlusion. We have two specific terms which we'd like to identify. One is what we call overjet, or horizontal overlap. And this is the distance that exists between our mandibular incisors and our maxillary incisors. Now, our mandibular incisors are generally located inside of or posterior to our maxillary incisors, and there's a little distance that occurs, and this distance varies. We've got a Bowley gauge or a measuring device, which is commonly used in dentistry, and we can measure the distance in which these teeth overlap, or what we call overjet. Actually, it's a horizontal relationship. And here we're about 2.5 millimeters or so on our measurement scale. This varies considerably depending upon the way the teeth grew, and also possibly even some habits that have occurred. Thumb-sucking habits will frequently cause these anterior maxillary teeth to protrude rather significantly, and sometimes this overjet will be rather significant. Here we're dealing with about 5.5 millimeters overjet, which becomes much different, and it'll vary in almost every individual. We've got another term which refers to our overbite, or it's our vertical overlap. And I think this skull, even though it has a few fractured teeth here, shows it a little bit better. And that is the distance that our mandibular teeth bite onto the lingual surface of our maxillaries. And if we were to take a pencil and draw a line right at the incisal edge of our maxillary teeth, we would have about this much vertical overlap on here. And again, we could take a measurement device and such as our Bowley gauge and actually measure in terms of millimeters. You got a strong spring on this mandible. The degree of overbite that occurs. And again, this varies quite significantly in these teeth. And we have a size variation that we should relate here. We didn't get into the size of our maxillary teeth specifically, but I think you can see here that our size, particularly width-wide on our incisors, start to vary considerably. On our maxillary centrals, we're dealing with about a width, a mesial distal dimension of about, was it 8.5 millimeters. And in our laterals, we're dealing in about 6.5 millimeters. So we got a total of about 15 millimeters in these two teeth on our maxillary incisors. Now, our mandibular incisors obviously are much smaller. Our mandibular central is about 5 millimeters. Our mandibular lateral is a little bit larger, 5.5. Now, we'll have to try to remember this relationship. Width-wise, our maxillary central is the largest, and our maxillary lateral is smaller than our central. Down on the mandibular incisors, we're the opposite. Our mandibular central is the narrowest of all the incisors, only about 5 millimeters, and our mandibular lateral is a little bit larger than our central, just the opposite of the maxillary, about 5.5 millimeters. This, I think, is of significance in relation to this occlusion. We're concerning ourselves with the way these teeth bite on an almost daily basis in dentistry, and we find that our mandibular central occludes or bites with our maxillary central only. And because it's so narrow, when we get to our mandibular lateral, it occludes or bites with both our central and lateral. And then when we go to our cuspids, again, we're biting with both. And from here on, in the rest of our posterior teeth, we have a half of tooth difference. Our mandibular teeth are a half of cusp or half a tooth forward of all of our maxillary teeth because of the difference in size of our two central incisors in our maxillary mandibular area here. A couple other terms we could point out at this stage. One is what we call a proximal surface. We referred to our surfaces from a mesial, distal, and labial lingual aspect. A proximal surface is a surface which approximates an adjacent tooth. And a proximal surface in here could either be the mesial surface of our lateral or the distal surface of our central. So proximal surfaces are our mesial and distal surfaces without specifying them. This leaves for a term for this space that exists in between the contact areas of our teeth. When it's a space below our contact areas, we generally refer to it as our interproximal area. And this is filled with our interproximal gingival tissue and our interproximal bone, and it's generally the space in between our two proximal surfaces. We also have another term which relates to this space incisal to the contact, and maybe we can see it a little bit better over here. It's a little V-shaped area that occurs in between the incisal edges and our contact area, and this we refer to as an embrasure. An embrasure is the space, a V-shaped space between the contact area and our incisal or occlusal edges in between our teeth. Let's look at our individual mandibular incisors here. We'll want to identify our mamelons again first. We can see them. We've got a mandibular central here with a mandibular lateral here. You notice the difference in size, and also there's some specific shape differences, which we'll get into and point out here as we get into the identifying characteristics. But we've got a little bit of identifiable mamelons on the central. Again, have a hard time finding teeth with these mamelons on. And also on our lateral, you can see our mamelons. Remember, we have 4 growth centers on these teeth. 3 of them are our incisal mamelons: mesial mamelon, middle mamelon, and distal mamelon. Then our 4th growth center is our cingulum. And frequently these will leave the little depressions, which is just at this stage a terminology review here for you. Your mesial labial depression or groove, and your distal labial depression or groove. Let's look at an individual tooth here, and we'll start to review at this stage our individual terminology on this. First, let's look at our incisal angles, and notice something special about our incisal angles of our mandibular centrals. This is only true of our mandibular centrals. Our incisal angles are not only very sharp and almost 90 degrees, but equal in sharpness on both the mesial and the distal. So equal, we can't identify which is mesial or distal. We'll also notice that our tooth is fairly symmetrically fan-shaped over our root, or what's called bilaterally symmetrically located over our root. It comes out in a fan shape and sets right over the root of the tooth. This will vary a little bit from the lateral. We'll go to pointing out. If we looked at the labial surface in this direction, we'd see that our height of contours are about the same. We're down in the cervical third on both our labial as well as on our lingual. A couple things that might note here, and that is that our cingulum is not as prominent on our mandibular incisors as it is in the maxillary. And we are not quite as evenly convexed on our labial surface. Our incisal edge is still over the center of the root, quite centrally located, but we have a tendency to develop a flattened area from the height of contour up to the incisal edge, or possibly an incisal 2/3 of our central incisor. One of the characteristics of this is that it does have somewhat of a flattened incisal 2/3 on the labial surface. Of course, our lingual surface has got the usual concavity. Our height of contours, or what may be our contact areas, are located very close to the incisal edge, and again about equal on both the mesial and the distal, or the distal and the mesial. I can't tell which is which myself here. If we look over to our lingual surface, we'll find that the anatomy is basically the same. We have basically the same terminology, except that our marginal ridges are not nearly as prominent. And I turn this back and forth here a little bit, and you can try to see the marginal ridges. They're not prominent at all, really. This is almost a flat surface across here. We still term these areas our mesial marginal ridge and our distal marginal ridge, or sometimes we just will call them our marginal ridges. And we still will have a general term, which is our lingual fossa. We just never see a pit on, I shouldn't use the word never because somebody will find one, but I have never seen a lingual pit on these mandibular incisors. Very small marginal ridges and not greatly distinguishable from our lingual fossa. It is very characteristic of these teeth. If we look to our root, we will find something that is quite characteristic. In our view from the labial, we find that the root is quite narrow. Actually, the whole tooth is considerably narrower. Our crown is only 5.5 millimeters wide instead of 8.5 like the maxillary central incisor. But when we look to our dimension from the labial to the lingual, or our labial-lingual measurement, we find that this is about 6 millimeters in dimension. So actually we're broader in our mandibular incisors, both of them as a matter of fact, from the labial to the lingual than we are from the mesial to the distal. This is just the opposite of the maxillaries. And so we have a very broad root from labial to lingual and very narrow in our mesial distal dimension. This leaves for what we call a flat or a ribbon-shaped or a bow-shaped root. If actually we were to take and look at a cross-section of this, well, even before we do, let me point out the thing that makes this what is called ribbon or bow-shaped. And this is a common groove that exists in many of these teeth. You can see it much better on this surface, possibly. And this has got a variety of names. And this can be called a depression, it can be called a groove, or a concavity. Here we call it the proximal root depression, the proximal surface. It's in the root, and it's a depression. Or we can call it a proximal root concavity, or a root groove. So we've got a variety of terms that this can be called, and they're all essentially correct, and various descriptions and terms will be used for different ones. Notice the total shape of our root, and that is that it comes down quite symmetrically to an apex, which again is located just about directly over the incisal edge. Our crown length is considerably shorter than our, not considerably, but a little bit shorter than our maxillary. We're involved in about a millimeter, millimeter and a half short on our incisal cervical crown length than what we had in our maxillary central. And our overall root tooth length from the apex to the incisal is somewhat shorter than our maxillaries. But because of the crown length being a little shorter and our width being a lot shorter, it gives this tooth a long, narrow type of appearance. If we look to our lateral, and maybe the best way to start looking to a lateral is to look to it in a comparison type of shot here. We have a tooth that is a little bit broader. It's a little bit broader from the mesial to the distal. We have a tooth which has a little bit longer crown length from the incisal to the cervical by a half millimeter or so. And actually the crown total tooth length is a little bit larger. So this tooth generally, overall, is just a little bit larger. Our tooth has got a distal incisal angle which is rounded on our lateral and should be significantly more so than our centrals, which are very difficult to tell apart. Fact is, our centrals are so difficult to tell apart that in our spotting characteristics we won't ask you to identify right from left in our mandibular centrals, but we will very significantly in our mandibular laterals ask you to identify right and left. One of the reasons being this distal rounded distal incisal angle, which is more rounded than the mesial. We have a situation here too in which our, let's look at an individual tooth here for a minute. Find it, here it is. In which our tooth is said not to be completely symmetrical or bilaterally symmetrical over the crown. It's referred to as asymmetrical. Insomuch as our mesial surface frequently will be a little bit straighter over the, here we are, and fan shape, but our distal surface has a tendency to bulge out and be a little bit more prominent. This is where we pick up this extra half millimeter in width, is towards the distal as we get a more prominent bulging in this area. And if we relate this back to the arch form, this is where our tooth is starting to turn the corner in the arch, so as to speak. And it's reaching out to start to turn the corner. We have this, all the basic terminology here as we had in our central incisor. One thing I should point out in both our central and lateral, and that is our cervical line. Our cervical line has the same basic conformity as far as being close to the apex in the center of the labial surface and coming closest to the incisal on the proximal surface here, whether it be mesial or distal proximal surface. So it has a very distinct curvature, but the distance at which it comes closest to the incisal on the mesial and on the distal is not nearly as prominent. We may say that it comes a little closer to the incisal edge on the mesial than it does on the distal, the same as our maxillary incisors did, but it's frequently not enough, particularly in our centrals, to tell a specific difference. Now, if we go to trying to identify these teeth and review with you some of the spotting characteristics of them, we first of all have to identify the central from the lateral, and some of these have been pointed out to you. Our centrals have very sharp incisal angles, and they are equal on both mesial and distal. They are V or wedge-shaped right over the center of our root. It'd be called bilaterally symmetrical. And conversely, in our lateral, it's a little more rounded on our distal incisal angle, and we have a little bit more of a prominence on the distal area. And of course, our contact area normally, or our height of contour, is considerably closer to the cervical on the distal than what it would be on the mesial of the lateral. What sometimes becomes confusing in the identification of these is these teeth wear or abrade very significantly in the mouth, and frequently they'll be, completely abraded down to an area in through here. And then we still have to, make identifications on these, and we have to start relying on other characteristics. If you've got a perfectly normal shaped tooth without any wear or without any caries or other damage to it, it makes it easier to identify. We indicated that on our central, for an identifying characteristic here, we have more of a flattened incisal 2/3. This doesn't exist quite as prominently on our lateral. Our lateral has a tendency to be a little bit more curved in our incisal 2/3. Now, the difference in size of these teeth is a little bit misleading, in so much as when these teeth are not in the mouth, they're hard to relate size and say one that is larger and one is smaller than the other. Another characteristic which I think we want to point out between these two teeth, and maybe again I'll use this one here, that is our line angles. Our line angles on our labial surface are generally quite sharp, and on our central they're quite even. On our lateral we have a nice sharp even mesial line angle, but on the distal this line angle has a tendency to round right into the cervical third, and it's not quite as sharp in the cervical third as it is on the mesial. And again, this is where the tooth is starting to twist or turn in the arch, and as this does round, we practically always will have a deep root concavity or depression on the distal surface of our lateral. Now, we can have this concavity on either the mesial surface of the lateral or mesial or distal surface of our central. And the fact is, these particular teeth have it in every surface. But the distal surface of the lateral is one area where you can say you practically always have a concavity. And if you get one that doesn't have a concavity, you better find out whether it's a different tooth, because the distal surface of the lateral generally always will have this. We can look to the incisal on these two teeth. And maybe I can turn it around and get a little better light on it this way here. Yeah. This is an area that helps us in our identification rather significantly too, but it's an area that is often difficult and confusing to the student. Our central is frequently said to be, our incisal edge is perpendicular to a bisecting line through the labial lingual portion of the tooth. Whereas in our lateral, this starts to turn the corner, and our lateral is not perpendicular. Our incisal edge is not perpendicular to a labial lingual line bisecting the tooth. It has a tendency to swing towards the lingual on the distal part as it rounds the corner of the arch. I'm not sure this one shows it real well. Let me see if I got one here that shows it a little bit better possibly. And again, we might be best to try to show this in contrast to another tooth. Sometimes this is difficult to see. Yeah, this one is showing it a little bit better. As far as this incisal edge starting to twist here a little bit. This kind of makes the cingulum on this lateral incisor appear to be swinging towards the distal also, as it's starting to turn. Now, you get a sharp contrast. Some of them are very symmetrical, and some of them are very significantly twisted on the axis here. And then you get a large area of them that are kind of in between. And this makes for difficulty in attempting to distinguish between these two characteristics. But I think this shows real well, and is the key that you want to establish in your mind. Here we're at right angles to a line bisecting the labiolingual portion of the tooth, and our cingulum is right in the center of our lingual surface. Whereas on here we've got a little bit of an axis which twists, and our cingulum kind of swings towards the distal also. These will be the major characteristics which will help us to identify the teeth. We can't really use the cervical line significantly because it's quite equal, but we can use our incisal edges as to the twist, can use this fan-shaped portion on here, can use the flatness that occurs more significantly in our central, in the incisal 2/3. We can use this rounding of our distal line angle, the distal labial line angle, right at the cervical part here. And we can use our distal root concavity, all as kind of keys in attempting to identify one tooth from another. Let's take a look at our pulp morphology. Here we have a mandibular central incisor, and we have a mesial-distal section. Our pulp cavity now is the cavity surrounded by dentin in which the pulp occupied when the tooth was vital or alive. And we have some terms which we'll review here for you. The coronal portion of our pulp cavity is called our pulp chamber, and the root portion of our pulp cavity is our root canal. We also have our apical foramen, and we have pulp horns. Here the pulp horns are not showing very prominently. These pulp horns change with age and the maturity of the tooth. It's an older tooth, rather heavily worn, and the pulp horns are just not as visible. If we were to look to a labial lingual section, we would find that our pulp cavity is much broader from the labial to the lingual. And again, this is in relation to the external morphology of the root. We have a very wide root from the labial to the lingual, and very narrow from the mesial to the distal. So we have a very broad one in this dimension, and this occurs both in our pulp chamber as well as in our root canal. If we look over to our lateral, we'll find that, again, in a mesial-distal section, we have a fairly narrow pulp chamber and root canal. Here our root is a little bit longer than in the central usually, and sometimes we'll have a little bit of a curvature towards the apical portion of the root. And again, if we look on down to our mandibular lateral in our labial lingual section, we find that we are broad again, fairly broad in the labial lingual section of this particular pulp. And again, this just basically follows the external morphology of our root. We hope this information will aid you in the study of your mandibular incisors.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.